an old bacteria, very smart, is outsmarting us for years, tens of years, not only in the fact that we never managed to get rid of it, but it's outsmarting us in becoming resistant to different antibiotics that we use to treat tuberculosis. And that's how we have the different forms of drug-resistant TB, from one drug that is resistant to 2 to 3 to 4, to the forms that are the scariest ones that my colleagues, I hope, will mention, the extreme drug resistant that basically are resistant to a lot of the drugs that are usually used in the treatment. Drug-resistant TB and its more complicated forms as MDR and XDR are a horrible diagnosis to have, difficult for people to go with it, difficult for doctors, nurses, healthcare providers, community workers to deal with it, as well as not just the individual, but the family around him. So we want to make the case that, and to make people understand that drug-resistant TB is another important, essential aspect of antimicrobial resistance, not only because this bug is so complicated and resistant, but also because it's spread through air. And while a lot of the attention in the antimicrobial resistant sphere is on antimicrobial resistance in the hospital settings, you know, the bugs that are becoming resistant in the hospital are on the corridors, are on the surfaces, are in the operating theaters. TB is in the air. So we need to make sure that everybody understands that this is a very serious situation, and everybody understands that drug-resistant TB is an intrinsic part of the conversations that are happening on the AMR. In September 2024, there will be a UN high-level meeting on antimicrobial resistance. And as you all, I hope you know, and you will hear about soon, is we will have next week, actually, more or less exactly in a week, but on 15 May, there will be a multi-stakeholder hearing happening in New York, similar to what we had for TB, in which different stakeholders, especially civil society and communities, will be in New York to share their views around UNHLM for antimicrobial resistance. And after that, there will be a period that will be with launching their declaration, as well as last time, discussions on the antimicrobial resistance declaration that will happen with the culmination in September when it will be adopted. From the Stop TB side, we felt that we don't afford to be quiet or to be divergent. We need to be very united because TB, we have Mycobacterium tuberculosis that I refer to, but also be aware that there is also Mycobacterium bovis, and I imagine most of you are aware. And as you know very much, the aspects of One Health and animal health is very much part of the antimicrobial resistance conversation. And we have a lot of lessons to share and things that can be done that together, convergently, TB and AMR can go together towards ending this by 2030. We will try to make the case. It will not be easy. And I want to warn all of us here that the AMR community at large, and I'm not sure if we have in this call, we tried to get some AMR community representatives here. And we didn't manage to get some of the core ones, even though I have to tell you that during WHA, there will be a conversation on AMR that will take place on 29 May lunchtime. And we are in the process of making, because we secured one of the biggest advocates for AMR, Sally Davis from UK, agreed to join us. She wanted to join us today, but she couldn't do it. But what I want to say is that the AMR community doesn't necessarily see TB as part of the AMR conversation. So it will not be an easy task for us to be part of it. My last 2 points will be, it should not be one against each other. We should embrace each other's agenda. And we should not go and saying TB is more important, or but we should recognize the AMR conversation and challenges, but also the TB ones, we have the same problems. The AMR community discuss a lot about how to protect the drugs against bugs becoming resistant to them. We speak about the same. I think several of us are terrified at the idea that we might have a bug that is resistant to bedaquiline, right? And how do we protect that? And we are all terrified about the fact that we can produce new things, but we need to ensure access to people for them. And the access should not come necessarily with restrictions and barriers, but it should be facilitated in a way that still we don't use the efficacy of these drugs. Diagnosis is complicated, and so on and so on. So common agendas, but we need to make everybody understand what's the case. So with that in mind, I will stop here myself. I am really happy to see that we are close to 200 people, which will be a very large number of participants. I'm very pleased to have you all here online. And I want to start with our first speaker to share the thoughts on MDR. I don't think you, Sherry, have need any more presentation. We gave I want to give you the spot on this because I know that USAID is not only that invest so much in the TB response, but you care so much about MDR, about drug-resistant TB, about community, but also protecting the drugs. So if you can share the thoughts from you as the biggest donor in the TB space. I know you don't like me to highlight that too much, but it's a reality. And from your perspective on the TB and AMR, if you can share your views with us. And thank you very much.
Yeah, thank you, Luchika. It's great to be here and to talk about such an important topic. I think what you said is we need to come together as one community. This is where we rise or fall together, right? We're not going to be able to set up the systems that are needed for MDR-TB without benefiting AMR and vice versa. And we need to look at it that way, of this thing where we really need to intersect and see these connections. It's obviously, been 100 years almost since the first antibiotics were discovered and in use. And so we understand that there are systems that need to be in place and that we need to protect the antibiotic use, but we also need to develop more. We understand we need to actually have the capacity in countries around the world to actually develop these new antibiotics, and we need new classes of antibiotics. We shouldn't have to wait another 50 years for the next new class of antibiotics. This protects everyone. This develops our arsenal of being able to adjust to nature, to resistance. Resistance is going to happen. We know that. And so how we work together to address this, I mean, this upcoming meeting, the high-level meeting in September, is a really important time to say, we are united on this issue. MDR is a key component of that. And we can help pave the way for a lot of policy and advocacy and research. But we also need the larger AMR community to be working with and to be strong. So I think this is a moment where we shouldn't be looking at one or the other or what fits in or doesn't fit in. We should be looking at the broader issue and how do we address this together globally. And we need all of the countries to have strong lab networks, pharmacovigilance systems, treatment capacity, strong policies, guidelines. So all of these things are needed around the world. And so as we look at these key asks, I think they're very basic things that we should be doing together. So let's not say, like, is MDR in AMR or not? Of course it is. It's part of it. And the question is, how do we work together? And here at USAID, we're leading on that. We have a group that's working on AMR in a broader sense. And then we have our TB programs, we have our malaria programs, we have other programs that are working more broadly. But let's look at how we're actually working together, especially to to get high-level political commitments in this AMR meeting that's coming up in September, that would include MDR-TB and would include other things, to really see how are we going to protect the people? How are we going to protect the next generation, and make sure that they have antibiotics that are available for proper treatment? So I call upon everyone to come together on this. This is really a moment where we should be supporting one another and finding ways for those synergies, and building that capacity. It's really critical for our families, and for the future generation. Thank you, Luchika, and I look forward to hearing from others.
Thank you so much, Sherry, and I really appreciate your point of coming together. And I really hope that everyone in this call, everyone can do a little bit. And as you said, it's not about our own agenda or where we come from and so on, but it's about indeed shouldering, and it will protect not just one or two, but all of us. So let's keep this in mind. I really very much thank you, Sherry, for this call. It fitted very well, and I can confess we didn't even discuss together about this, but it's such a great message. So we wanted to have here a clinician, somebody that actually does a lot of work with drug-resistant TB and MDR-TB, because I have to confess, it's at least 20 years, since 22 years, that I didn't see or consult or look at or treat a person with drug-resistant TB or MDR-TB. So that's why we have here with us Erlina. Erlina is a clinician from Indonesia. That is her bread and butter is MDR-TB, if I can call it this way, even though I should not think of bread and butter when I speak about MDR-TB. But Erlina is also from the private sector, because she does private work, and she's also a board member for Stop TB. But you are here because you are a clinician treating people with MDR-TB. And please, if you can, share with us what it means these days to be treating MDR-TB, and what are your views and what your future thinking, and how would you argue about the importance of MDR-TB into the into the AMR conversation. And for the colleague that asked the question, if I can share this link, please share the link with your friends. That's not a problem. And I kindly ask Ishan and Greg to monitor the question and answers that are placed, that we can address them, because we plan to have a half an hour discussion at the end. So without further ado, Erlina, please go ahead.
Hello, everyone. Good evening from Jakarta. Hi, Luchika and Sherry. Thank you for giving me the opportunity. I really like this session because we talk about drug-resistant tuberculosis, which is, I think, also got less attention. And we have to remember that drug-resistant tuberculosis is a part of antimicrobial resistance. And what is happening, the cases is increasing. But the way we look at it, the way we give attention, I think is still not optimal. Why am I saying that? Because we have a lot of missing cases in DR-TB as well, just like sensitive TB. And that is very dangerous. Why? Because if someone having drug-resistant TB and not being detected and not being treated, this person will be a source of infection to others. That is very dangerous. So that is why we have to find them and we have to treat them until the end. And what is happening now, there are some effort to diagnose, to find these cases, but still are not very optimal, since I think I would like to say that the diagnostic tool for this DR-TB are not deployed equally in many places. So we have still limitation of diagnostic tool for DR-TB. And even if we found them, they are not all of them initiate the treatment. Not all of them enroll for the treatment. I would say from my experience of treating DRTB since 2009, most likely just like 70 at the most, 70% of at the most, that those diagnosed DRTB patient enroll for the treatment. And out of the 70% of patient that getting the treatment, not all of them cured. I think 50% default. There are so many reasons for defaulting. Let's say loss to follow-up due to side effect and a very long duration of treatment. So I'm very happy that now we have the short regimen, BPAL and BPAL-M. But I'm also understand that this new regimen is not yet available in many places. So I would like to urge all the attendees, 210 attendees here, who are having voices to their government. Please ask your government to find this DRTB patient, not only diagnose, but also put all of them on treatment until the end, until they get cured. And I would like to say, but please, I apologize that our attention, clinician attention, and also government attention to drug resistance is not as big as sensitive TB. I mean, it's not sufficient enough. Well, the fact that the estimation of WHO of incidents, it is not got all the cases. I mean, we do not find the cases as many as the estimation. So with this kind of situation, I would like to say that we have a problem. And this is very dangerous if we do not treat DRTB until they're cured, because the transmission will go over and over, and many more people will get the disease. And treating DRTB is very complicated, a lot of side effect, and etc. So please, my colleague here who are attending this webinar, talk to your government to put more attention, especially also to put attention in helping private sector, because 50% of this patient also goes to private sector. And I want to say that private sector not have a good capacity in diagnosing and treating the DRTB. So we have to also put some effort, some investment to this private provider. And please also increase and enhancing the public-private partnership in order to find these cases, to treat them until the end and cure. And also advise, advocacy your government to invest more money to provide let's say PCR-based diagnostic to diagnose easily, and also to provide new regimen for the DRTB, because 6-month regimen, I have experience in Indonesia. We are very proud to share the experience that with BPAL and BPAL-M, the treatment success is really good. For BPAL itself, from our operational research, the success rate is 97.3%. That is never happened before. Our DRTB treatment success rate before this BPAL and BPAL-M is just like maybe 53%. And right now in my country, more than 600 people getting BPAL and BPAL-M regimen. So let's get together, unite together, as Sherry mentioned, do the best thing, do everything that we can to for us to put more attention, but not only talking, but also action, do action. And please do not make the stigma even bigger with DRTB. We have to diminish, or we have to make the stigma ended for TB and especially for the RTB, because a lot of the RTB patients get a stigma. They are being they get divorced from the husband. The children get will be put away from the mothers and etc. So stigma is still there. So not only investment and effort for diagnosis and the treatment, but also invest for education to eliminate to end stigma. I think that is my share for now, Luchika. I can talk more and more, but maybe for another occasion. Thank you.
Thank you so much, Erlina. Very inspirational, very good points from somebody that deals every day with you know, people with TB, with drug-resistant TB, and you know, different genders. And excellent point on stigma. We all have friends that suffered a lot due to their diagnosis of TB or drug-resistant TB and so on. I want to say that in the chat, in the question and answer, as well as in the chat, we have questions, so we can look at them. I think, as I said, we will have time at the end for them. I actually also asked my colleague James to touch base with a colleague called Ishan Arora, who seemed to have go through a long extended time on treatment and suffering a lot. So we will, you know, the TB survivors, we have networks of TB survivors in different countries, so we can see how we can link you up there. And now we will not go into the questions, but please put them there that we can see them, and we can prepare the answers and see who can answer what. And then I would like to go because I believe that in this call we have a lot of colleagues from civil society and TB survivors, and we are all here, and actually the UNHLM should be about civil society and should be most and foremost about the TB survivors, about the survivors of the different type of resistance to antibiotics and so on, which are in itself heartbreaking stories. So for today, we chose two colleagues, two ladies that went through a lot of drama and became strong advocates and activists on their turn. And I would like them not only to tell their story, but actually, as Erlina, as actually Sherry said, what will be your call? What will be what you would like to see happening for this UNHLM on AMR? What are the things that we will we can push forward? And I will start with Oksana Ruxineanu. She's an MDR-TB survivor from Republic of Moldova, a friend for many of us, for me for sure, and a warrior because she didn't give up. Not only that she didn't give up, but like many of you, she's pushing forward the agenda and the advocacy and the activism on TB. So Oksana, please go ahead, my dear.
Thank you, Luchika. I think it's a great topic, and very many participants here joining actually shows how important the topic is for people, because we do care for those who are affected now, and we are trying to get the best standards of care for them in the country. My name is Oksana Ruxineanu, as Luchika said, and I'm the Executive Director of Society of Moldova Against TB, an NGO organization based in Moldova, but first of all, I am a drug-resistant TB survivor. My personal antimicrobial resistance experience is a strange related to TB. I was diagnosed with TB and started the treatment for TB in 2007. Unfortunately, months later, I was informed that I have a drug-resistant TB. A second-line treatment was not available at that time. I followed 1 year of treatment with the first-line drugs, with injectables added to the treatment. However, as it was expected, the treatment was not successful. And only 1 year later, once the drug-resistant treatment became available in Moldova, I started the treatment of second-line drugs and completed it successfully 24 months later. As per overall, my TB journey lasted for 3 years with terrible side effects, as I often say. I had vestibular disorders, eye disorder, renal and liver toxicity, seizures, headaches. And as it was not enough having more than 20 pills a day, I was periodically forced to complete my treatment for drug resistance, treatment to treat side effects. With last long slogan, you have no options, just do it. So I did it, and I was committed to fight the TB and to help others once surviving TB successful. So we founded a TB organization in the country, and since then we are striving a lot to get the best for people affected and people with disease. And now, after years of stagnation in TB wars, now we have actually very good accomplishments. We can now prevent tuberculosis in 1 month. We can treat TB, drug-accessible TB in 4, and drug-resistant TB in 6 months, respectively. But as the doctor said, this unfortunately, all these options are not available oftenly at the country levels. Therefore, drug-resistant TB remains a critical problem and a cause of global deaths globally. I myself could have been one of these statistics if not treated timely and properly. One of the reasons that so many can continue to die from drug-resistant TB is, as Luchika said, that TB is actually neglected from the MRI agenda, being always an afterthought or among this justification that this is not the right time, you have another time, you need another platform, let's do it later, and so on. We don't have time. We have people who are in eager crisis now, facing difficult situations and trying to survive a disease which actually can be prevented. So I think that including drug-resistant TB in the agenda is critical to successfully address the issue. But in the same time, we need to understand that TB is not only a biomedical discussion. Many people face human rights barriers when trying to access services for diagnosis, treatment, care, and support. And AMRI should be based on a people-centered approach and equally address barriers and challenges, including those related to human rights. We know that there are a lot of resources. There are very important tools developed which need to be considered seriously. We need to provide services according to the best WHO recommended standards of care and strengthen insectorial mechanisms to ensure the access of vulnerable populations to integrated TB treatment and care. We know that Stop TB Partnership and Global Fund have supported and continue supporting countries globally to undertake TB community rights and gender assessments, stigma measurement. The legal environment and human rights scorecard was developed recently to shed light on the relations between laws, policies, human rights, as well as it gives us possibility to document the degree to which the TB responses in countries are equitable and right-based. We have a key and vulnerable population estimation guide, which helps identify and join dialogue at country level the TB priority groups and helps understand the extent of TB in these groups to better plan efficient TB interventions. We have community-led monitoring tools, very important, such as One Impact, and we have Ukrainian experience as one of the best, which is helping to document and overcome human rights-related barriers in real times, where civil society, affected communities, and government are all working together. Such tools could be used for antimicrobial resistance as well, in addition to the TB, HIV, and pandemic focus. As going forward, I think that it's absolutely necessary to say that we need to put drug-resistant TB in front and center of all antimicrobial resistance discussions, policies, guidance, and at the same time, we need to empower the process by strong political commitment. We still need to invest much more in research and development to develop TB vaccines, better and acceptable treatment regimens for people from the perspectives, and make those tools which are already developed available and accessible to people and countries. We need to use person-centered approaches in designing TB responses and focus on aspects of the treatment journey that matters most to people with the disease and affected by the disease, of course, by allocating sufficient resources. And of course, we need to consider equally individual patient health, public health, global health, in a way to ensure respect to persons, beneficiaries, to make the treatment person-centered, from one hand, and from the other hand, to ensure public health good by preventing transmission, protecting the community, and contributing to global solidarity for assistance to reduce barriers to quality TB diagnostic, treatment, and care, with all respect to communities' rights and gender. And of course, an important, extremely important tool for civil society and TB survivors is to continue monitor and document reasons for not initiating, completing, or discontinuing the treatment of people. We need to strengthen surveillance and advance accountability to translate those very nice and ambitious global targets into national level targets to be implemented. And in this way, to ensure that everything which is available is actually at the country, deployed at the country level. Thank you. That was my message.
Thank you so much, Oksana. Very good appeal. I actually think if you have a moment, Oksana, to put this as bullet points, I think they are really very good to use, as well as Erlina, not just you. And I hope, Annie, that we can use them for all our, inputs and asks towards our leaders, towards our, country governments. The UN high-level meeting is not done by aliens. They are human beings from our countries, are our representatives, are our ministers, the governments that are there to represent the people. Unfortunately, they very often forget that they are there to represent the people. And then after they finish their job and return to the people, they become even more vocal. So we should use some of these asks that you did to really push that forward. Good. Thank you, Oksana. I'm looking now to Ani. Ani is coming from Indonesia, and she is as well an MDR-TB survivor. We specifically chose two ladies. I think that as women, the burden that we carry is very big because it includes a lot of stigma. I think sometimes much more stigma on women than on men, but I stand to be corrected as we will further evolve into these conversations on stigma. But sorry, I stop here and I will give you the floor, Annie, for your points. Thank you very much. Annie, please go ahead. Thank you.
Thank you so much, Lucica, and I hope my voice is clear enough to hear. My name is Ani Harnasari, and I'm MDR-TB and also DS-TB survivor from Surabaya, Indonesia. Good evening, all. Here is already 8:30 p.m. And now I lead the TB survivor organization called Rekat Peduli Indonesia Foundation. And I'm also on the steering committee at the TB Women, at the global network of women in all diversity who are affected by TB. And at the global level also, I'm a vice chair of the TB CAP. My life with TB is I have firsthand experience on drug-resistant TB is about in 2011. So, and I experienced drug-sensitive TB, the second one in 2016. So I also have TB and a pregnancy. So yeah, especially when I have the drug-resistant TB, I have to dealing with injection every day is about 6 months. And also every day I have to take about 15 pills and don't have any miss for a day. So that moment, my life also feel same like Oksana. I have full trauma, also experience with pregnancy. So I have like double depressed because I have to think about my medication, and also I have to think about my child that still on my body. And that moment also I have experienced that I have treated not humanly and also not treated with dignity just because I have TB, especially for MDR TB. So, and now I'm glad that we already available for the 6-month regimen, BPAL, and I'm happy that they are like Professor Erlina said that we already implemented and more than 600% that already treat with BPAL. And my point is there is a significant opportunity to drug-resistant TB target, and that is already agreed that should future for the EMR to be strengthened. And we know that to strengthen the DRTB target, we have to contain in the UNHLM document and should be a future for the EMR. We still realize that much work is need to be guided that is already ready. And we also have a set of key asks during the TB multi-stakeholder hearing in the New York. The TB accountability report of the TB affected community and the civil society that the priority to close the deadly divide was launched that moment. And it is a shared product of us as community with offer that 1,000 TB survivor network and organization from 92 countries shaping these 6 call to action that already future. First, we know that we need target, like my colleague already said. We need to find the missing million. We know that in 2080, we have had a clear numerical time-bound target, and we had them for people with TB and also drug-resistant TB, children with TB, and preventive treatment for both people living with HIV and close contact of people with TB. This must future again, and we must commit to find, diagnose early and treat is about 40 million people with TB, including 1.7 million people with drug-resistant TB. And we still have 3.5 million children. So yeah, we need a political declaration because political declaration without target is a declaration not worth having at all. Second, to have the missing million to reach the target, we need innovation, like Dr. Erlina said. So like those we have discussed, for this we need dedicated financing from donors, but also significantly, we need to scale up domestic financing for TB as well. So we need to ensure that we have the investment. We need to have an operational accessible TB vaccine by 2025, we hope so. And we saw that how quickly vaccines came into the market during the COVID-19. So we must ensure that we have a new TB vaccine as soon as possible. It will save more lives. And the third, innovation are only useful if everyone can access them. So we know that part of the challenge here is the human right and gender-related barrier. In 2018 also, we had strong commitment on TB community right and gender, the CRG. So my country, Indonesia, has conducted TB CRG assessment, TB stigma measurement assessment, and also has implemented the TB community-led monitoring with the support from the Challenge Facility for Civil Society from the Stop TB Partnership for accountability in TB, like One Impact in Indonesia, which called Lapor TBC. So as community, we insist on target for country to do this work as the key. I say that all countries to conduct the TB CRG assessment and also to develop a national costed TB CRG action plan. So My last point is to be a champion of people with TB. People like me, be the champion that ensure ambition in the political declaration, ambition with target, financing, innovation, and also human rights. Ambition that will be end this epidemic by 2013. That's from me. Thank you, Lucica.
Thank you very much, Annie. There are very many questions in there. Your interventions was great. And I like the questions that are coming up, but we need to go through the agenda first. I just want to make sure that we have the emails of everyone that asked questions, because I want to really make sure we answer all of you. There are very good questions. Some of them are not necessary for Stop TB. I know that Teresa and the colleagues from WHO will join or are joining. Teresa will join us from WHO Global TB Program, the director. She's joining us in 15-20 minutes. There are very generous questions. So Ishan and Greg and the colleagues that worked so hard on this, let's make sure we capture the contacts of the colleagues that asked the questions. We are going forward now, and I know that I saw a question from Robin on this. We actually developed a set of key asks for the UNHLM on AMR. Sahu will speak about them. And more than that, we are very happy that we have a version. We can always improve it. As we know, documents are living these days. But we have a version that several colleagues that are going to New York for the multi-stakeholder hearing, around 15, will be able to use it and to flag it and to raise questions and points from it next week. So Sahu will go and will share components of the key asks with all of us here. And then Greg will share quickly in 5 minutes things about the multi-stakeholder hearing that is happening that are things that are happening in the, not only next week, but also between next week and September, and how we can be there as united and as vocal as we can, and how we can pressure together. We might be in need to write some letters and do some open calls for people to really make sure that TB is a voice that is going to be heard. But without further ado, Sahu, why don't you go ahead with the key asks, please? Thank you.
Thank you, Ruchika. Great to see all of you connected here. I will briefly talk about the key asks document, which is being released today. These are the key TB asks for the UN high-level meeting on AMR. It is a document which is very short. I think it is just 4 pages to read. And we would encourage all of you to download it and read it once it is on the website. So first, to start with, so these TB key asks were developed not by just the Stop TB Partnership Secretariat, but we followed the inclusive process. We consulted with our board. We sent some drafts to our board, the TB working groups that we have, several of them, and a number of other partners that have contributed to this key ask. We got a lot of feedback to include a lot of things. Of course, you can make it a book, big one, but we realized that this is opportunity for advocacy within AMR to put TB in there. So it should be some high-level points and captured in a way that is that is easier to articulate in a UN high-level a meeting, and also could go into the political declaration that is expected out of it. So it is not a very detailed document. It is a summary document, but it tries to capture all the different feedback that we got. Just to focus a few things that it talks about in the beginning. TB is the #1 killer amongst all infections. Here I emphasize single infection. If you compare to any other infection, #1 killer in terms of numbers of deaths per year. Drug-resistant TB is, as Oksana put it, the front and center of antimicrobial resistance. Here are some numbers. WHO estimates that 410,000 MDR TB, multi-drug resistant TB or rifampicin resistant TB developed each year. That's each year. But let me also point out that this is just rifampicin resistance TB and multi-drug resistant TB. There are other forms of TB beyond this which have even bigger numbers. For example, if you look at isoniazid resistant TB, that is a bigger number. That doesn't include here, but at least we have 410,000 MDR or RTB per year. And we must also note that so we should also note that MDR TB comes with high mortality, as many of you stressed here in this meeting. 160,000 deaths due to drug-resistant TB in 2022 in 1 year. If you compare it with what has been published as antimicrobial resistant deaths that are attributable to AMR, it is 1.27 million in a year. So 160,000 out of that is DRTB, which is a big number. So anyway, you look at it, it is a big burden of drug-resistant TB. I must also point out, and I think Ruchika mentioned in her remarks as well, that TB does not just restrict to humans. TB has an animal component. There is bovine TB, which affects animals, and there is zoonotic TB, which transmits from animals to humans. Many people perhaps may not know that zoonotic TB, which there are some estimates that 140,000 people get affected each year, it is by definition actually resistant to a common anti-TB drug, which is pyrazinamide. So if you look at drug-resistant TB, the point I'm trying to make is at least 410,000 a year, but it has a bigger dimension in humans as well as in animals. Now, sorry. So the key ask document comes in different buckets. The key ask grouped into different buckets. The first one is the ask in political commitment. Here, the ask is to recognize TB as an urgent threat posed to the world, as a single biggest infectious killer, but also as a leading cause of deaths amongst the antimicrobial resistant infections. The numbers are there. The second thing that is being asked there is TB should be considered as a tracer indicator in the global AMR response and strategies, because progress in TB, both in R&D as well as in implementation of care and prevention, is actually a progress towards, is a good measure about progress towards AMR targets. So here, there is also mention about some of the things that people wanted to mention here, the research and development part, but also surveillance, also some the tools that are broader and not just for TB, but it could address multiple AMR issues. So this is about the political commitment, which is the first bucket of things that are being asked. The second is the financing part. Now here we have taken it directly from the TB political declaration, the UNHLM political declaration of 2023. So we assume here that there should not be any problem in referencing it in another, and also inserting it in another political declaration coming just 1 year after the AMR political declaration. So here the need for TB funding, both care and prevention and research and development, are being flagged. If you recall, the political declaration of UNHLM 2023 said $22 billion US, not million, billion US dollar per annum for TB care and prevention, and $5 billion US per annum for research and development. And just to remind us, on the right, if you see where we are currently, WHO reported for the last data that we have 5.8 billion for TB care and prevention available. So long way to go. Also, the TAG and Stop TB report on research funding put the research funding at 1.1 billion for 2022. So a long way to go in increasing the funding, and we must make a we must push the financing part into the AMR political declaration and the discussions. It also mentions in the research and development a number of things, including the drugs, shorter regimen, vaccine, all of that people wanted to put there without going into too much detail, because it's not a technical document, it's a political document, but it has all of that. The next bucket that the key ask is talking about is diagnosis, treatment, and prevention. Here we should recall that the TB UNHLM 2023 declaration had some targets. We have put it there as 45 million people to be diagnosed and treated for TB between 2023 and 27. And out of that, 1.5 million are people who are suffering from drug-resistant TB. So that's an existing commitment. It will be great if that can be referenced and also committed in this AMR political declaration. There is a commitment there. There is a key ask there to commit to ending the drug-resistant TB epidemic through a series of actions, and they are all listed there. These are things that we regularly do in drug-resistant TB, but also some things that some things that probably we are not doing so well, and there needs to be more action on these things. Just to put the status currently on the right side, and this is what I wanted to say that we are not doing well, is we know that more than half of the drug-resistant TB that is estimated to develop in a year never gets to diagnosis and treatment. In 2022, if you look at the WHO report, out of the estimated 410,000, only about 178,000 were diagnosed and initiated on treatment. And this 178,000 is a combination of MDR, RR TB, plus also the XDR and pre-XDR TB. So over half of these people are actually missing from care. And this is not acceptable. A lot of things have to be done. This is an opportunity in the AMR political declaration and the discussion to flag this and ask for things that are needed to reach with prevention and care services to everyone who is in need. Then it also talks about in this section, it also talks about antimicrobial stewardship, which is very important for all the existing antibiotics, but also new ones that will come in so that we don't lose the antibiotics quickly. It also talks about infection prevention and control measures. And here we are talking, because it's TB, particularly on the airborne infection prevention and control measures that are needed to prevent drug-resistant TB infections. But these measures also will act on any other infection that is airborne, AMR infection that is airborne, and if it also includes other infection control practices beyond airborne, it will address also all infections. Then there is also an ask to recognize the potential of Stop TB Partnership's Global Drug Facility, because it has done a lot of work in TB to make TB drugs accessible to countries, affordable, and quality assured. And that mechanism can be available for other drugs and diagnostics used in other AMR pathogens. Then we come to the section which is on community rights and gender. Here we are focusing on human rights-based approach, gender transformative approach, stigma-free approach, and a people-centered approach, and also asking for resources to be allocated for engagement of the community in all these, all these aspects. It is also mentioned there about the Universal Declaration of Human Rights, the International Covenant on Economic and Social and Cultural Rights. These are existing UN-endorsed documents which we feel should be easy to reference and ask for inclusion in the AMR document. It will help TB as well. And the right to health in the context of AMR is very important. And then we have a part also on the research and development. Well, research and development you saw is covered in other asks, also a bit of that. Vaccine, shorter regimens, diagnostics, but here it is specifically asking about research and development and focusing on vaccine but also as also on drugs and use of newer techniques, even research and development on human R&D on human immunology and newer AI-driven strategies of tackling AMR. So those are the key asks. The last part of it is the health system and accountability. There is a section about include TB services as essential elements within national and global universal health coverage strategies. TB should not be left out of them. And also to recognize the One Health approach. And TB has a One Health approach because it has the manifestation in humans as well as in animals. There is also a proposal there is also an ask to go for an accountability mechanism, which should include an independent panel on AMR, an annual report by the UN Secretary General. So those are the key asks that are in the document. We would encourage you to read the document and also use it, and also feedback to us about the contents as well as what else can be improved there. So I would stop there. Thank you.
Thank you so much. I think we have a very active chat and also Q&A. So we have a lot of questions in there. And some very specific questions. And I just want to say on one of them that are the governments doing enough to combat the disease? No. And that's why, like the next one, colleague Elizabeth, this was a shock. And then Elizabeth says about Ghana. I think we need to, it's not just in Ghana, it's in many places that the governments are not recognizing TB for what it is, as a big infectious disease killer, airborne, and with forms that are also resistant. So indeed, you're right. The situation is changing if the governments are committed. We saw great leadership in countries in Asia, especially India, Indonesia, Philippines. I think Bangladesh will follow. I think Pakistan will follow. It doesn't mean that there are no problems, and there are many problems in these countries, continue to be. But once there is some leadership, there is a bit more visibility, still long ways to go. But before that, I want to give the floor to my colleague, Greg, who will share a few thoughts, a few things that we are planning during the multi-stakeholder hearing in New York next week. And after that, I don't know if my colleague Teresa joined, but if not, anyway, Greg, you go ahead. And if not, while waiting also for Teresa, we can go ahead and discuss some of the questions and answers. So Greg, why don't you go ahead, 5 minutes, please?
Yeah, so we'll have an amazing group of TB advocates going to New York on behalf of the TB community for the multi-stakeholder hearing next Wednesday. We'll have representatives from Uganda, Ukraine, Indonesia, Ghana, DRC, Mongolia, and a few others. So I think we can share their names in the chat, and you can get in touch with these people who will sort of act as regional representatives who will be at the hearing. It's going to be a smaller group than last year, but hope to be just as loud and carry the amazing spirit we had at last year's hearing. Many of you will remember us all chanting "Yes, we can NTB." So we hope to carry that energy to New York next week. And I think our key job is going to be to champion these key AMR asks that Sahu's just told you about, and make sure these key asks are visible, and make sure TB is not left behind. The hearing is going to be webcast, so everyone can tune in, and we hope you'll join and support those of us that will be there in person. We'll also be meeting with various UN missions to push for these key asks. We had an amazing group of people that were there last year, and those mission meetings were so critical in making sure that TB was front and center. So we'll be, again, meeting with missions. And again, we're happy to update you on which missions we're meeting with, but we hope to have a good round of meetings. Looking past the hearing next week, towards the high-level meeting in September. We don't know exactly when the first draft of the declaration will come out, but I think the best guess is end of May. So we'll keep you updated on that. But that's going to be a really important process. And like last year, we're going to need to follow the negotiations closely and speak up loudly and clearly to make sure that TB is included. And same as last year, your engagement at country level, I think, is going to be really key to making sure we get those key asks in the declaration. And one thing I think we learned from last year is that it's not just about getting words in a TB declaration, in the AMR declaration, but it's really about engagement in your capitals and making sure that your governments at the capital level are engaged, and especially reminded of the commitments they made last year in the TB declaration. So we know that getting things in a declaration is not an end in itself, but it's a great opportunity to reach out, to have those meetings at national level, and to make sure that people haven't forgot about the commitments they made last year in the political declaration on TB. So that's where things are at the moment. Your support will be really critical. Do tune into the AMR hearing next week. As I mentioned, we'll be there to represent you. We're going with a great group of advocates. So keep in touch, and I think I'll pause there. Happy to answer any questions anybody has related to the hearing next week. Hopefully many of you have registered. Many people heard back and had their registration confirmed last week. Those of us that will be going will try to make a statement. So again, you can get in touch with those representatives who will be going if you'd like them to convey any messages. We know from last year's hearing that there was often not enough time for everybody to speak. So we hope this year there will be more time, so people that are taking the time to travel there will have the opportunity to be heard and have their voices heard. So that would be great. And maybe I'll pause there, and again, happy to answer any questions. Thank you.
Thank you so much, Greg. So 2 points briefly before I give the floor to you, Teresa. Thank you for joining us. I know you had meetings to attend, and good to have you here with us. Very impressed with everyone here. A very active chat, a very active question and answers. I think, Teresa, we are also speaking about attendance for the multi-stakeholders hearing. So I don't know if there is a plan to have colleagues from WHO or funded by WHO there, that if there is anything, it's good to be a TB group all together, calling for that. Before this, I want to say that as we saw last year, the big push will be actually between May and kind of late August or mid-August, when the declaration will be negotiated. After the declaration is negotiated, of course, in September, it's good to have good speakers, it's good to have a presence, but actually the text is done, let's say by 1st September. So it's very important to clarify these things and to make sure that between, let's say, 15 May and 1st September, there needs to be a lot of push from our side on that conversation. And I don't know if anyone is aware, there is a question that just came up about the digital participation in the multi-stakeholder hearing. Laila, if I take it from how it was last year, the answer is no. I imagine they will not change much, but I don't know for sure. So I don't know if Teresa will know anything more about digital participation for the multi-stakeholder hearing. But thank you, Teresa, for being with us. Of course, we are all the same because we are all TB warriors here. And my, my frustration or my ambition is that during WHA and forward, we get a lot of non-TB people in the room because we are all on the same boat here, very much on the same boat. I see some names that I don't know, but I know they are very much linked to our TB efforts. So I'm very grateful for them being with us. So Teresa, from the WHO perspective on the TB and AMR and your points, thank you very much. And please go ahead.
Chika, thank you very much for organizing this important webinar. Really impressed by numbers of people who joined, and very sorry that I've missed the important part of this conversation. But I'm sure, as always, Luchika, you are unanimous. You've done a great job. So from my end, from the side of WHO, I would like to brief you on a few things that are ongoing. As you know, from the WHO engagement, the technical department who is responsible for the topic is the one mainly engaged in all the activities, and it's AMR division. who in WHO coordinating efforts from the side of WHO, and also through the One Health platform, because an AMR topic and platform is kind of crowded with many important players, not just from health sector, but also from agricultural and other sectors. And so that's why it's a complex a bit, and many important AMR related topics are pushed forward. But here in WHO, we are working closely with AMR division, and there are also few former WHO staff who are working, and one of these persons who is working for AMR division several years, but with the TB background, I will disclose, is Kefar Samson. Probably many of you know him. He worked for GTB. And he is engaged in the preparations, and of course we've tried to share our experience, and based on our 2 high-level meetings, and also they're fully aware what are the linkages that are clearly seen and articulated in our political declaration. There are specific points showing linkages between AMR and the MDR-TB, and highlighting that MDR-TB is a major contributor, and also the linkages, how to strengthen the surveillance system for AMR in general, using TB as a entry point and the pathway. So this is also very clear, and it's there. And we hope that so the MDR-TB will be visible in this AMR request. But of course, it will depend on the position of the member states, and their voices, first of all, should be there as advocates and bringing this problem. Also, what we've identified, observed during our interaction, not that only the issue of many players with their own agendas, kind of competition. Also, another issue that by many countries, AMR as a problem is, and many people in general, is taken like something theoretical. So everyone knows about AMR, but nothing concrete. And with TB, again, we have real opportunity to showcase, because no one understands clearly how AMR is killing people. So what does it mean? So how it comes, but with MDR-TB, again, we can make clear case, because we have clear numbers. We've organized many surveys, and by the way, the whole AMR surveillance system strengthening is based mainly on the experience of MDR-TB. And we should bring this background, these clear examples, how AMR can kill people and what it means for many years for TB community. So then another point about our concrete targets, we have very concrete targets, 1.5 million that should be treated over the past 5 years. And as I know, they are learning from our targets and commitments, and they would like also to have something concrete, I mean community, AMR community in their declaration. And in general, our declaration, it was brought as a kind of the best example that should be followed. That's why we should not be surprised if there will be some similar things seen in the AMR declaration. It's good that we were given brought as an example. But in terms of key asks that could be reflected, TB specific, in the AMR declaration, we should be realistic. So we cannot take the core things from TB declaration and try to embed them in AMR. It will not happen. And so that's why the best thing, on my view, would be to agree unanimously what will be the key points, maybe 1 or 2 that could be comprehensive and include all our key requests, and could be proposed and presented to the member states. And if they will decide to push them forward, this will be the best way through the powerful voices of member states to have unanimous opinion that is agreed across to include 2 maximum key points, because more than this, it will be difficult to expect. And of course, strong reference and reaffirmed commitments from the TB declaration. They should be recognized and highlighted in general, all these commitments, plus 2 specific points related to MDR-TB. And I would like to acknowledge great work done by Stop TB Partnership. Greg shared this key ask that collected from all the community, but let's work on them further and try to consolidate, maybe to make it more concrete and packed. So this is for now. Unfortunately, we will not be able to participate in the multi-stakeholder hearings, I mean, the GTB staff. But there will be colleagues from AMR division for sure, and with a strong background on TB. And we will be in contact, and we will have our the New York team, WHO New York team, who will be also engaged closely traditionally. So that is the situation for now, and thank you very much for your attention. I don't know if I met your expectation and shared some important information from my end. Thank you.
Yeah, thank you, Teresa. Very good points that you raised, and also very good news to hear that Kefas is, who is a long-standing, indeed, TB champion, I would put it, even is following on this. And, you know, we need to obviously buckle up, all of us, with a TB heart. So thank you very much for this, Teresa. We have now 15 minutes left. As we said, we will regularly not only organize this type of webinars, but share what is happening, you know, and where we are, and how can we make our points very strong. Our voice at national level will be crucial, because actually the member states are the ones agreeing or disagreeing. And there are, of course, some countries that will have a stronger voice than others. And there are some countries that are negotiated. I don't know how much you are aware in the UN, there are grouping of countries to make it easier. So some countries come together. For example, for the G77, I understand that DCM Uganda will negotiate. So, you know, the leadership of Uganda, as well as the mission in New York, as well as our advocates and activists from Uganda, will be very important. But of course, the negotiator will have to listen to the 77 countries behind, so we'll not be able to do more. Now, we have a huge amount of, so first of all, we started the 220, we are 160 now, so it's a great, we have a lot of questions that are here, both in the Q&A and in the chat. I think, and some of them we can answer, some of them can be from, you know, other colleagues that can answer to them. Our internet, or at least my computer, is a bit idiotic today, because I cannot move my arrows here. There is a questions, there are some specific questions here. There is a question asked from the Teaching University Hospital in Nigeria that is very specific about the results of GeneXpert and the resistance and so on, that I think, Erlina, you can look over it. You don't need to answer, but maybe you can suggest an answer to that if you see. It's about the GeneXpert results that came with a change after 3 days. There are some good points that were made throughout this session about stigma. And I think there is a lot of discussion that is happening around stigma, and we will try to push for a movement around zero TB stigma that we should have in TB. And we have some tools from Stop TB. I don't say that they are everywhere. The so-called the One Impact community-led monitoring, which is a tool to empower people with TB not only to know about the disease, but also to enter into dialogue and so on, but also to address the social stigma effectively. And linked to stigma, I want to say that I saw that our colleague, the journalist, I think Alpan, so I cannot move, my screen is frozen, but I know that I read the question at a point. You know, she said that indeed the people with TB are a bit reluctant to share their stories. I totally agree, but I also want to say that more and more we have people that are keen to speak with journalists and share their stories. So in case you need to have people that are available to share their story, please do not hesitate to reach out to us, and we can put you in touch with people from almost every country that are TB survivors. I think there is some points that I think are relevant here. There is a point that I think I read at a point which was related to and I want to know if Sahu and Teresa, I don't know, or Erlina, you have a reflection on that, which is the risk that unsupervised TPT can generate resistance to isoniazid, and how do we deal with it? So that's one. And the other is about drugs that are available on the market, drug-resistant TB drugs that are available to the market. I think it will be interesting to check on that, you know, how much restrictions are or should be and so on. So I don't know if you want to share a bit of thoughts on that, these 2 points, while I try to see what I do with the rest of the questions.
Luchika, I will answer some of them.
Yes, please.
Okay, regarding the expert examination, we all know that the sensitivity and also specificity of expert is very good. It's more than 95% even. So expert PCR-based examination is being recommended by WHO, and also in many countries now is being used to detect DRTB. But the problem is, as I mentioned earlier, that there are not enough PCR device that's available in the country to detect all drug-resistant patients. So that's why I said that there is same thing happen in DRTB. We have a lot of missing cases. That's one thing. And even if those who are the cases that we found, are not all of them initiate the treatment or enroll in the DRTB treatment. And we also have a lot of lost to follow-up cases. So this also this problem increasing the transmission. So this is our job, our homework, to make like a recommendation or ask our country or any stakeholder, even the pharma or business company, to help us to have access to this PCR-based testing for the DRTB, because it's this a really a good way of detecting than using other conventional one. And regarding the question of stigma, yes, a lot of our patients, due to stigma, afraid to come out and tell that they are having tuberculosis. Not only that, because of stigma, they don't want to be tested, even though they have symptoms. So again, this lead to increasing transmission. And the third one, I would like to address the question of TPT. So yes, there is potentially resistance happening if we don't supervise this TPT, especially from the diagnostic. So we have to rule out a TB in order to give TPT. If you don't do that, you might give TPT to people who actually probably having TB because you didn't rule out TB. So, but for the HIV patient and children under 5, if they are close contact, nowadays you don't need to test them, but directly give TPT. So, but again, please be careful to other than the HIV and children under 5 group, you have to make sure that you rule out TB in order to give TPT. Thank you, Luchika. Over to you, Luchika.
Yeah, go ahead.
Yeah, maybe I can say a few things there. First of all, thanks for the questions. I think we are flooded with a lot of questions. I don't know which questions to take, but since Ruchika mentioned those two, I think Lina answered some of them. I just wanted to highlight that we should not be worried about TPT causing drug resistance. And as Arlena said, if you don't exclude TB, then there is a risk. And there are guidelines how to exclude active TB and then give TPT, then there's no risk. Remember that latent TB infection for which you are giving TPT actually doesn't multiply. The bacteria is not multiplying, so the risk of drug resistance is not there. But if you don't exclude active TB, that's a problem. And I wanted to also touch upon the question, interesting question on the expert trace. So yes, when bacteria is in small quantity, the results will be traced and repeat test is recommended, in fact. And I must also highlight that here we should be, we always say about person-centered, people-centered. Why are we becoming so test-centered for treatment? The treatment initiation should be done in a person. So it is not just the X-ray or an expert result, but there are a number of other things that a person who is assessing the person has to make, assess and then take a decision on whether to start treatment or not. I think that's an important thing that we should look at. But yes, stress is an issue, and repeat tests are recommended in that kind of setting. I see Teresa's hand is raised. So Teresa, please go ahead.
Stay aside of this important conversation and thank my colleagues Arlena and Sahu for the comments, but would like to remind that use of antibiotics require proper counseling, proper diagnosis, and completion of either TB preventive treatment or TB treatment itself. So this is not a secret, and all these essential conditions should be in place. And I agree also with the Sahu that we should know that there is no evidence showing risk of any risk of TPT for the causing drug resistance. Of course, proper diagnosis and differentiation active disease from the infection is required. And also, just referring to WHO guidelines, we're recommending where is possible, it's not mandatory, skin tests, new generation of skin tests for detection of TB infection. And we have good news that some of these products will be already quite soon pre-qualified by WHO. So this gives more opportunities. So in terms of diagnostics, of course, we are looking for better options right now. By the way, there is ongoing guidelines development group meeting where we are looking at and we'll update our recommendations at the TB diagnosis. We are following all the trials. There is more evidence coming, and we hope soon also to have even point of care tests. Let's hope that it will happen. But it's good to use this platform for this specific, so this discussion, because I see there is a lot of relatively new audience, and the fact that they're interested is very important. So let's use this AMR agenda to bring more people to know more about TB.
I agree, Teresa. I think actually after this, and as I told you, we were more than 200 and we had an incredible number registered. I think we can do more, and I think we can have some things around even on One Health and other aspects that we know, but I think it will be much more important to share with others as well. I note, Pamela, your points about men and also about using One Impact and helping on the issue of stigma in TB affected communities. I want to recognize what you, Teresa, mentioned about the test, looking at the tools to have a possibility to look at check the sensitivity to BPAL and BPAL-M, and we go forward. As Juan Garcia asked, I think I think there was a question, and I will end with that. I don't know if any of you will dare to go to that, which was around how long should people with drug-resistant TB be hospitalized, and should they stay till their culture is becoming negative, or how long they can be in the treatment. And as we know, many years there were a lot of debates about this. So I don't know if any of you guys want to say something around the hospitalization of people with drug-resistant TB and MDR. I don't know, Oksana, I saw you open your your camera, so maybe Oksana, and I don't know I don't know if Erlina or Teresa or Sahu you want to add, but Oksana, why don't you go ahead?
Yeah, thank you. Yeah, I think it's very critical for people to understand that as long as we provide efficient treatment, there is no reason to hospitalize people. And we've tried to change this approach in treating TB per general, to have people to be treated in community. And as long as we can provide and ensure an uninterrupted treatment, we can have all the drugs necessary. We are following the best WHO recommendation. As long as much within 1 week, a patient will not actually be any, let's say, infectious and presenting any danger, as we call, I don't like this word, to community. What is important for us, that we usually shift the focus to people who are in treatment, and we forget the people who are not, who actually are missing. And this is the huge, our huge gap. We need to find people and put on treatment. As long as there is treatment, there is no need to put them in hospital. And we are still, at least in our region and Eastern Europe and Central Asia, we're still facing this challenge with doctors giving so much importance to hospital when the conditions are absolutely vice versa, and we have everything, having good drugs, having treatments, having good diagnostic tool, is to make people on treatment in the community level from the first day of the diagnostic. So that's my opinion. Thank you.
Good. Thank you so much, Oksana. So Sahu and Teresa and Erlina, 1 minute each. We are beyond the time, but it's an important topic. So, yeah, go ahead.
Yeah, I'll be very quick. So I think we should follow the principle that unless there is a medical indication, people should not be hospitalized, whether it's TB or MDR TB or drug-resistant TB. We have today a regimen. We must remember it is for drug-resistant TB only 6 months, 3 to 4 drugs, same as TB. So we should not make it more complicated. We should not disrupt people's life. We should not hospitalize people unless there is a medical need for that. For example, if there's a side effect, there's a life-threatening thing, some investigation that requires hospitalization. Otherwise, no need for hospitalization. Thank you.
Thank you, Teresa, and then Erlina.
To respond to the important questions, and I've seen in the chat question about TPT for MDR TB contacts, and would like to use this opportunity to highlight WHO recently released rapid communication, which will be followed by the guidelines, because GDG Guidelines Development Group meeting already happened. With one of the focus areas is on the TPT for MDR TB contacts, and we finally received new evidence from 2 good trials from South Africa and Vietnam that allowed us to recommend 6 months regimens of levofloxacin that should be recommended for MDR TB contacts. And this is a new opportunity. Please follow our guidelines and use it.
Thank you, Teresa. Very good call. Erlina, please go ahead.
Okay, thank you. The recommendation for the drug-resistant TB treatment now is ambulatory. No need to hospitalize the patient. Many patients refuse to be treated because they're afraid of being hospitalized unless there is a medical purposes. So ambulatory, no hospitalization.
Thank you very much.
Thank you.
With this very clear points, ambulatory, no hospitalization, but also all the other calls, we want to thank you very much. To be honest, I learned 2 things. I learned a lot from every speaker here, but I also understand that we can do much more in speaking about drug-resistant TB and, you know, the different aspects of drug-resistant TB. because there were so many questions around this. Now, we need to keep in mind that we, as we all said, we have an opportunity to bring even much more light and support to drug-resistant TB through AMR, as we can do through TB and drug-resistant TB for the AMR movement. So it will be very important to keep this in mind. We will for sure follow up with other webinars. There are several questions that we didn't answer. I counted at least 8, and we will do our best to answer them. And also, we will not only follow up with webinars, but also to mobilize ourselves for this hot summer, as we had last year, in preparing ourselves for the UNHLM AMR. I want to thank you very much, all of you. You were all very busy, but I'm very impressed and honored to have so amazing speakers and all of you. And I like that Seth keeps writing, and thank you, Seth, for putting all the comments in there, and for all of you participating and being with us here. We can have one about availability of drugs, indeed, Ferdous and somebody else who raised the point of availability of drugs and what can be done. We should do one with them as well. Thank you so much. Have a good afternoon.
Thank you, everyone. Bye-bye.
Take care of all of you.